Hi everyone. My name's Ashley Spalla. I'm from the Miles4Hips team. I'm the Education and Information Resource Chair, and I'd like to introduce to you today Dr. Joshua Wellington, who's a pain management specialist, here to speak to you for our theme week. Dr. Wellington, would you like to introduce a little bit about yourself?
Yes, hello everyone. It's a pleasure to be with you, Ashley, and everyone who's seeking out information. My name's Dr. Joshua Wellington. I'm based out of Indianapolis, Indiana, originally from the Midwest, Ohio. I went to medical school in Toledo at the Medical College of Ohio, and then did training in physical medicine and rehabilitation at Harvard, followed by pain fellowship training at Harvard in pediatric and adult pain medicine. I came back to the Midwest to Indiana, where I took residence in 2004 and have been practicing pain medicine, specifically focusing on advanced pain therapies such as spinal cord stimulation and spinal drug delivery with implanted pain pumps for the last 19 years.
Very impressive. Why did you pursue physical medicine and rehabilitation?
Physical medicine and rehabilitation was a specialty that came to my knowledge early in the process of medical training. Many medical students are unaware of it until their fourth year of medical student or medical training, and it's too late to choose it as a specialty. But I was fortunate to actually be interviewed by a physiatrist when I was looking to enter medical school. And I just had an immediate connection with her. She had a wonderful perspective on medicine and comprehensive care and a team approach that just really spoke to me. And so that was one of the first rotations I did when I was able to take an elective, and just fell in love with the specialty because it's really function based. And that's what I really liked. It's about quality of life. And there's so many different aspects within physical medicine that someone can pursue, be that musculoskeletal medicine, traumatic brain injury, spinal cord injury, or orthotics and prosthetics, or in pain medicine, which is where I ended up following. But I really just enjoyed the functional aspects and how there was such a focus on quality of life.
Very cool. What is the role of a pain management specialist, specifically on a hip preservation team, on the surgery team? What would you exactly would you do?
I think that the role of a pain specialist is to really, again, seek out the best means perioperatively for someone to control their pain leading up to a surgery, the surgery plan itself, and then after the surgery. There's a lot of data that support, being able to use judicious medications appropriately, and opioid class, nonsteroidal anti-inflammatories, and other adjuvant medications. There's good data that show that if people are tapered off opioids just before surgery, that they'll have a better post-operative course. And then trying to find the best medications for each patient around the time of a surgical procedure and after, and being able to appropriately transition into therapy and get off of opioids in order to not potentially incur other side effects. It can be a challenge because everyone is different. And so it's trying to find the best approach for each person.
I can definitely relate to that. Um, what types of anesthesia are used in hip surgery for our patients who aren't familiar with that?
So not being an anesthesiologist, but a physiatrist, I still work alongside anesthesiologists, and I'm actually in the anesthesia department at Indiana University currently. Um, Anesthesia can take many different forms. It can be a general anesthetic where a patient has a tube placed down their throat, a breathing tube, and then are monitored as anesthetics are given to induce an unconscious state. A patient can have sedation where they're in a twilight state and they might be given a regional anesthetic block, block of the femoral nerve, the sciatic nerve, to try and help reduce pain and reduce the need for oral and IV medications after surgery. There can be other medications that can be used, like ketamine, to try and help to use a non-opioid medication to bridge the gap from surgery to the post-surgery process, and try and control pain and minimize discomfort for a patient. So the anesthesiologist's role is really to work in conjunction with the surgeon to try and develop a plan that's going to be best for each individual patient and what the surgical process might entail, and then transitioning to the postoperative care.
Are there complications with anesthesia, or can there be complications with different types of anesthesia?
There can be complications with anything. Any medical procedure, unfortunately, carries risks. Anesthetic risks can be, very low, but if it happens, then it can be very serious. With airway management, our breathing, if there's an issue with maintaining an airway, I mean, that's how we live. We have to be able to breathe. And if there's an airway issue in the middle of surgery, that can be emergent. So anesthesiologists play a very critical role in the surgical process. Complications can happen with anesthetics, although it's very unusual. Complications can happen with regional blocks, but again, it's very unusual. Most regional anesthesiologists are very familiar with the use of ultrasound guidance to be able to place needles as safely as possible next to nerves in order to block that structure. There's been a lot of advancement in the field of ultrasonography and the use for nerve blocks, whereas in the old days, the anesthesiologist would just use landmarks on the body and not have that visualization. So the risks have reduced significantly with the use of ultrasound guidance. Although, again, there are always risks, small risks of bleeding, bruising, small risks of nerve injury, risks of complications such as the development of pain syndromes, like complex regional pain syndrome, which can develop sometimes after any kind of surgical procedure to an extremity or after an accident. There could be other surgical complications like compartment syndromes. There could be infection. So there's all different kinds of complications that could potentially occur. Thankfully, they're pretty low in terms of the risks and the rate of complications. I think it's really important to talk with your surgeon, to talk with your anesthesiologist, to know what their specific rate of complications is and how they manage them.
Is there any things patients can do to reduce the risk for complications for anesthetic or going into surgeries in any way?
Definitely for anyone who is smoking tobacco, they need to quit. That is number one in terms of risks that are controllable. Very difficult to get off of tobacco because it's quite a powerful addiction, but we have means to be able to assist with that. There are very strong data that tobacco smokers have increased risk for infections and complications. And so that's number one going into any kind of surgery. Also, just trying to maintain the best health that you can through good nutrition, good sleep, going into a surgery as balanced as possible in that regard. Again, lifestyle modification. If people are obese, it can be, again, very challenging to lose that, especially if your mobility is impaired. But weight management can also play a factor. There are actually data in the orthopedic literature that to prevent the development of complex regional pain syndrome, again, a rare complication, but it's a nerve pain syndrome, that that taking vitamin C, 500 milligrams twice a day for 2 months going into prior to a surgery and then continuing that can reduce the risk of developing complex regional pain syndrome. So there are things that people can take into their own hands to try and help reduce their risk profile.
Wow, that's great information. How is pain typically managed?
One more thing
Go
that I
ahead.
thought of actually,
Go
for
ahead.
anyone who is diabetic, managing your hemoglobin A1C, which is the long range gauge of your overall blood sugars, and making sure that your hemoglobin A1C is as close to normal as possible, because most surgeons will not do surgery if it's above 8. And so that would just one other thought that I had about in terms of complication management for people who are diabetic. making sure that they're working on keeping their blood sugar low and to have as close to normal of a hemoglobin A1C as possible. Sorry, your next question was?
Oh, no, you're fine. That's wonderful information. Thank you. How is pain typically managed after surgeries, especially a large orthopedic surgery?
That can vary depending upon the surgeon and the hospital system. However, typically it's going to be with IV oral or IV and oral opioids. Usually IV initially, because intravenous opioids will give the quickest pain relief. They can be given administered by nursing staff. That may be even in the form of a PCA, or a patient-controlled analgesia, where you press the little button to be able to get pain relief. That has safety lockouts so that you're not able to accidentally overdose. Also, nursing staff can be given orders to give intermittent doses based on patient request. The goal is to then transition off of IV medications and onto oral medications. Typically, it will be oral opioids initially, but trying to transition off of them as quickly as possible and onto things like Tylenol and nonsteroidal anti-inflammatories.
Speaking of NSAIDs, what are the risks and benefits to long-term NSAID use?
So long-term NSAID use can be associated with risks such as gastritis, also gastric ulcers and bleeding. Again, that's lower risk, but with long-term use, it is a possible risk. That risk increases as we age. There is a risk that with high dose NSAID use that it could cause issues with your kidneys. And so you have to be very mindful of not overtaking NSAIDs. And although they can be used intermittently, if they are being prescribed long term, just to be monitoring kidney function potentially, and being very mindful of your stomach. And if it gets upset, to let your doctor know right away and stop those medications, because there is no withdrawal with stopping NSAIDs, and maybe consider switching to a different family within the NSAID class, because there are multiple different families of NSAIDs, and genetically we might respond differently to different families within the NSAID class of medications. And so by switching from one medication in a certain family of NSAIDs to a different family, you may be able to respond without the side effects you had previously.
Wow. Should a patient become concerned about becoming physiologically dependent to their opioid medication?
I think that is a consideration, because our human physiology with opioids is such that if an opioid medication is taken continuously on a daily basis, you can become dependent on it, sometimes in as little as a couple of weeks. And so that dependency does not mean you're addicted. That just means that if it is abruptly stopped, your body may go through withdrawal. Withdrawal is when the body is, again, dependent, meaning it's used to that opioid. And when suddenly stopped, you go into this cascade of feeling awful, kind of like the flu. And it's not life-threatening, but many people want to die. They feel so bad. And so opioid dependency is a reality when you're taking opioids on a daily basis. And so being mindful and working with your doctors to be able to taper down and off of opioids as soon as possible, I think is appropriate. And there's another component to that on the flip side of dependence and, concern for addiction, which is within the research on opioids that have been administered long-term, is a condition called opioid-induced hyperalgesia. And opioid-induced hyperalgesia, in plain English, is that the opioid, medicines like morphine, oxycodone, Dilaudid, if taken on a daily basis, can actually induce a hypersensitive state in the brain to pain. It almost amplifies your pain response, widespread, so that if you have pain in your hip and you're taking long-term opioids, the pain in your hip might slowly worsen. And then if you would have something happen, like let's say you walk into something and break a toe, your broken toe is going to hurt 10 times worse than somebody else who might break a toe, just because that amplification of pain, the opioid inducing this hypersensitive state, this hyperalgesic state in the brain, which is very real, but can't really be measured. You just feel pain much more intensely, and that's not the goal. And so with opioids, we know they can work very well short term, in a surgical sense, perioperatively, for treating trauma from accidents. But for long-term use, it has to be monitored quite carefully and judiciously, because the opioid-induced hyperalgesia, the dependence, although these things can occur, they don't occur in everybody. The dependence occurs in most people. The opioid-induced hyperalgesia, we believe, likely occurs to variable degrees based, again, on people's genetics. And so these are just things that, especially a pain physician is going to be mindful when monitoring patients throughout the course of their follow-up.
Wow. How do you taper off of pain medications with less side effects, considering all of that?
Yeah, so the basic rule of thumb is you do not stop cold turkey. That will it almost always cause withdrawal unless you're one of the genetically lucky ones who do not have withdrawal. And there are some people out there who I've encountered. But a general rule of thumb is to reduce opioids by about 25%. And that reduction can occur, again, variably every couple of days, every week. And this is where there is, I think, a lot of individualization to a taper plan. Some people are very motivated, they want to taper off and can reduce by 25% on a daily basis, just boom, 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 stair step it down and off. Some people are much more sensitive to opioids, their body becoming dependent on it, and might need to taper slower. And so I think it's working with each physician and patient to understand how that patient is experiencing the dose reductions, so that an appropriate taper plan can be laid out. In general, it's thought that people are going to be able to tolerate an initial 25 to 50% drop, and then reductions of about 10 to 25% thereafter. But again, the time frame, I think, can be variable depending on the patient.
Wow, absolutely. Are there hip pain management procedures that preserve the life of the joint or help manage pain that aren't necessarily surgery, like nerve ablations or PRP?
So injections into the joint can be considered, just intra-articular steroid injections. They can be done with ultrasound or X-ray guidance. I'm not familiar with the data on PRP or platelet-rich plasma. Same with things like stem cells. I think that that's experimental still. There have been attempts to do blocks of some of the nerves surrounding the hip joint. However, I believe that the jury's still kind of out on those data as to whether that might be beneficial, of blocking those nerves, of doing radiofrequency ablation to those nerves. So I think that that is definitely developing, where there are a number of pain physicians who are looking into that as possibilities to try and help manage the pain as long as possible until potentially joint replacement might be necessary.
What is the most important thing a patient should ask a pain management specialist prior to a hip procedure if they were coming to you?
I think it's just important to discuss a plan. Like, what is the plan, again, preoperatively, intraoperatively, postoperatively? What is that pain physician's kind of philosophies on managing pain acutely and chronically? What sort of tools do they have in their toolbox? Do they only going to prescribe medications? Are they going to consider maybe blocks? What is their relationship with the surgical team? And these are all important things, because if you're going to a pain doctor who has absolutely no relationship with the surgical team, that may be a challenge in terms of communication, or maybe not. I mean, I think it's good to get a sense of how well a communicator your pain physician is. You know, ask, have they assisted in other perioperative plans? Do they not hesitate to pick up the phone and call a surgeon on your behalf? Because those are all important pieces that can make a big difference in the long run.
Absolutely. What are the best aspects of being a pain specialist provider?
Best aspects I find is just the personal satisfaction of helping people's quality of life improve. It's incredibly gratifying to think that I'm privileged to have people who allow me into their lives and to try and help relieve suffering and pain, and that can make such a difference in each individual's quality of life. So it's remarkable. I think that the mythology of pain clinics being a place of moaners and groaners and whiners and complainers is honestly completely false, because it's amazing how many times you hear laughter ringing down the halls of our clinic and smiles. And I mean, there is pain, but pain doesn't mean you have to suffer. And there's ways of treating it and managing it so that it does not own you, and you are who you are fundamentally and not defined by your pain or your medical condition.
Absolutely. Love that. Well, we greatly appreciate your time and all of your information today. Thank you again. And thank you, all of our Miles4Hips watchers, and we will see you soon.